Thank you for joining our webinar this afternoon. I'm Caitlin Crossley from Optimity Advisors, and I'll be your moderator. Gareth Harper will be presenting. This webinar is about how to design a minimum data set to support evaluations. Before Gareth starts, I'd like to introduce today's speaker, explain how to ask a question using GoToWebinar, and finally, how to access the webinar recording. Gareth Harper is a senior manager at Optimity Advisors Europe and manages the economics team. Gareth's full biography is available on our website, or you can connect with him on LinkedIn. Today's webinar, How to Design a Minimum Dataset, is the last in a series of 6 webinars we have hosted on evaluation methods. If you'd like to listen to our past webinars, please visit our website. Before we get started, I wanted to mention that we welcome your questions throughout the webinar. All you need to do is type yours into the questions window, which for some is the 6th blue bar down on the GoToWebinar control panel, and hit submit. We'll get to as many questions as we can during the Q&A session following the main presentation. Finally, we're recording today's webinar and we'll post it on the Optimity Advisors website. We'll send you an email once it's up, in case you would like to watch it again, or forward it along to a colleague. I'd now like to hand the program over to Gareth.
Thank you, Caitlin. What I would like to talk about today is the data needs that are required to inform and support an evaluation, often referred to as a minimum data set. The kinds of issues which we're going to be thinking about are what kind of metrics could be included in an economic evaluation of a new model of care, and how are these defined, and what are the potential available and applicable data sources and indicators. But before we get into the details of those issues, I'd like to reflect back on some of the earlier work that we covered in some of the earlier webinars. This is, as you will recall, is the policy and evaluation and implementation process. The diagram on the left-hand side sets out the kinds of questions that an evaluation can ask. Should it work? Can it work? Does it work? What does it cost? Is it worth it? And is it affordable? And as you will also recall, these can be considered from an ex-ante or an initial perspective before the implementation, and an ex-post or an after consideration once data has been collected as part of the process and the implementation. And we've had a series of webinars around a whole range of inputs and issues affecting and contributing to the evaluation. This includes logic models, the healthcare system evaluation, readiness assessments, the concept of economic evaluation, and rapid cycle evaluation feedback. Informing all of these aspects is the need for data and information. And such data can come in 2 forms. It can be quantitative, through financial measures or counts of patients, and there's qualitative information as well, such as that of perspectives and opinions. A further way of thinking about the data that can be used in an evaluation is that it can be divided into different categories or groups. And I've thought about this and divided them here into 4 groups. First of all, you've got the health and social care aspects, which can consider aspects such as the clinical outcomes for patients, the processes that patients go through in terms of undergoing care, and their own potential patient experience. Secondly, there's a group which I've classified under economic and financial. These are the costs associated with implementation of new models of care, they're the resource utilisation that comes from that, and also the sustainability, to what extent are potential efficiencies and economies generated and sustained over time. Thirdly, I've thought about the concept of social and socioeconomic impacts, for example, behaviours, attitudes and perceptions of people, both staff and patients, who are affected by any changes. And finally, there's the concept of technology. Quite often new models of care will be relying on new and fast-growing technologies, and we may be interested in to what extent are these used and what are the experience of these users in undertaking and using the technology. And an important point to raise here is that data across these four domains, if you like, can come from a variety of sources, and I've listed a few of those on the right. They can come directly from patients or from their families and carers. They can come directly from healthcare professionals or the community care and community services. They can come from initial testbed or vanguard sites, or they could come from the healthcare system as a whole, drawing on administrative and administrative data and information that can be generated as part of business as usual. So, what is a minimum data set? Why is it important? Well, there's no really formally agreed definition, and it can be used in a variety of settings, both in terms of evaluation and in actual practical implementation. But in this context, what we mean by it here is a list of data, meaning its names, the sources, and the definitions of the data that can help answer the questions that are being posed as part of the evaluation of the new model of care. So what I'm really trying to cover here is, what are the kinds of information that people who are implementing new models of care need to gather, and need to understand, and need to put into an evaluation that can help those responsible for the evaluation report back to the decision makers and to the funders to answer the questions about should it work, does it work, can we afford it, and is it value for money? So, why do we need to do this? Well, first of all, we need to ensure that the evaluation actually answers the questions that it is set out to do. If we're interested in value for money, we need to make sure that we're collecting information on expenditure and outcomes. If we're going to use any existing data sources, for example, administrative data, we need to ensure that this data actually records what we need it to record, or whether we need to make some ad hoc adjustments or new data sources are required to inform that information. Thirdly, we need to ensure that appropriate data collection and reporting mechanisms are in place, either for new or existing data sources. And finally, actually doing this process of defining a common data set and a minimum data set can help ensure agreement and understanding amongst stakeholders about what is being measured and why. A good example here is, and I'll return to this later, capturing patient experience and outcome metrics is often important to gather the buy-in and the engagement of patients and stakeholders in an evaluation of a new model of care. What I want to talk about now then is what sort of metrics could be included in a data set. And first of all, I'm going to look at the issue of health and care outcomes. Here I've divided them into three types of groups, but there could be many more. The first are clinical outcomes. This measures the overall effectiveness and efficacy of the healthcare treatment and the medical treatment and the changes in the delivery of care through the new model of care. This could include healthcare outcome metrics such as life years saved, or could incorporate measures such as quality adjusted life years, or perhaps specific episodes such as the number of stroke-related disabilities or the number of falls. Secondly, we can look at processes. This is related to the amount of services that are provided to patients which are consistent with the routine care. So this can come from care records or patient-reported questionnaires, and could include, for example, the number of GP visits or the rate of emergency hospitalizations per 100,000 population. And thirdly, there's the aspect of patient experience, which I mentioned earlier. Quite often we'd be interested in understanding patients' experiences and satisfaction and the perceptions of service delivery and accessibility as a result of the new model of care. So we might be interested in collecting data from the feedback of patients about their experiences and their perceptions of the care that they've received. The second group, which I'd like to cover, are issues around economic and financial metrics, which, as I mentioned earlier, and relate back to our earlier presentation of the economic evaluation. Here we can think about the financial metrics, and these can be the indirect or direct costs associated with the intervention and also the new model of care. So we could be here looking at the total costs of care or the total cost per patient, or we could even be looking at condition-specific costs or episodic costs of care. Again, we could be looking at resource utilization, because we could be interested here in changes in the way that healthcare resources are used under the new model of care. For example, have we seen a reduction in the number of non-elective admissions in acute wards, or have we seen a reduction in the number of A&E attendances? And thirdly, we could be looking at the impact of sustainability. This is more of a qualitative aspect, and we might be interested in understanding to what extent could any positive changes that have come about as a result of the new model of care or intervention, to what extent could they be expected to last, or is it likely to end as soon as the interest and the initial investment has passed away? Here we may be interested in using focus groups or interviews to try and understand whether or not, for example, there are network partnerships and integration arrangements in place, whether there's adequate knowledge transfer, and whether or not there's appropriate infrastructure arrangements such as governance and management or organisational development and design arrangements have been put in place. Thirdly, third group I mentioned was that of socio and economic factors. Here we might be interested, for example, in behavioural changes, particularly say from patients. Are we able to observe a proportion of patients who now feel better supported to manage their long-term condition? Or are there groups who feel that they are more empowered to make decision-making? Or has there been better professional patient communication? All of these aspects are information which we may be interested in designing an evaluation. And secondly, there's the aspect of quality of life. We may be interested in trying to understand what impact on the overall quality of life for people with long-term conditions could be, and there are a range of tools and outcome metrics which we could use to investigate that. And finally, there's the area of technology. As I mentioned earlier, a lot of new models of care and a lot of innovative ideas about improving effectiveness and efficiency across the healthcare system are drawing upon new ways of using technology and information technology. And an evaluation might well be interested in understanding how effective this specific component of the new model of care has been. And there are two aspects we might be interested in. To what extent has this technology been used by the target group, for example? To what extent has new technology been picked up by GPs, by healthcare practitioners, or indeed by patients? And secondly, there's the impact, the whole impact on the experience. There may be significant take-up, but was it effective? Did it actually improve the user's experience? And we can identify measures here, for example, the percentage of staff who've undergone training for the intervention. To what extent has the help desk been used? And have there been any surveys or interviews with patients or staff who've used new technologies? And to what extent have they been recorded? And can they be used to inform the overall experience of the technology? So I've gone through the four areas there which I feel are important when considering what are important factors when designing a data set. What I'd like to talk you through now are just some important steps which I think are useful when working through in defining your data set and informing your evaluation. As with the situation as defining the overall evaluation, it's very important to define your objectives, describing what it is you want to measure and why, and how they link to the overall objectives of the evaluation. The second point, as was referred to in earlier webinars, the importance of getting this data and understanding what the baseline is. What is the current position, so that you can make a comparison against your current position when you undertake your overall evaluation. Thirdly, there's the issue around what is already available from administrative data and management information. Setting up new data collection mechanisms can be costly, both in terms of finances and individual time. So it's often helpful to identify what can already be used and collected in terms of existing data. And with that is the importance of understanding the frequency of that data and to what extent it's reporting in accordance with the timescales that's required for the evaluation. In addition to the frequency, you'd also want to make sure you understood any quality issues regarding the available data. For example, is the collection method appropriate? Is it covering the same geography that you'd be interested in? Or is it covering only a specific subgroup, whereas you may be interested in the entire population? So whilst the data may be collected for a specific operational purpose, it's important to make sure that that data is relevant for your own evaluation needs. Next, there's a very important aspect around appropriate data security and information governance arrangements. It is vital to make sure that any data you collect and store, you are consistent and compliant with data protection requirements. There will be an information governance officer in your organizations who can help advise what the Data Protection Act and the Information Commissioner's Office require in this respect. If, of course, there aren't any existing data sources, you may be interested in establishing new data collection mechanisms. if existing data sources are not sufficient. But again, you'll need to go through the process of understanding the frequency, understanding the quality issues, and again ensuring that your data security and information governance arrangements are in place for any new data that you collect. Then it's often helpful to test the acceptability of the data sources with the key stakeholders. This refers back to the earlier point that I made, that in doing this you can help improve engagement and understanding about what the evaluation is trying to achieve and the type of questions it's trying to answer. And finally, it's often beneficial to test the data within a modelling framework. For example, run a pilot scheme or an intermediate evaluation to test whether or not the data actually works, you can undertake your evaluation, or whether indeed you have any missing data gaps which you need to fill with a wider data collection. By following these steps and undertaking the consideration of the different types of data that you need to undertake your evaluation and defining your data set, hopefully what you'll end up with are the key components of a successful evaluation. You'll end up with a good understanding of the nature and availability of key data and their sources. As I said, it can also help with the engagement with a range of stakeholders if it can be demonstrated that certain aspects are included within the data collection and that meets their particular needs. And it can also help inform and develop a good understanding of what your future management information requirements are likely to be like once you go beyond the evaluation stage and into full implementation. I'd like to hand back now to Caitlin, who will now manage the questions and answer session.
Great, thank you very much for that, Gareth. We've received quite a few good questions so far, but as a reminder, if you have any questions that you would like to ask, we welcome them. If you'd like to submit them, you can use the questions box on the GoToWebinar control panel and hit submit. Gareth, the first question we have is, what if the data you want isn't available? How can we deal with this? And do you have an example of how you've dealt with this in the past?
Thank you, Caitlin. Yes, that's a common question and a common issue with evaluation. It comes from a number of reasons. One, for example, the administrative data that's been collected may not reflect the need. Secondly, you may well actually be asking a question in the evaluation that has never really been addressed before. Or thirdly, it might be the fact that you're looking at a geography or a service which doesn't match existing data availability. There are a number of steps that can be undertaken in this respect. The first is what I would recommend is to see and to undertake a wider search to see whether any other data from a similar area or from national data could be extracted and interpolated into your analysis. You will then need to undertake some kind of testing, sensitivity analysis as it's known, just to test the variability of that. But it's possible that you might be able to identify other data sources. Secondly, if that isn't possible, you might be able to draw it in a more qualitative aspect. So if you're not actually able to collect quantitative data, you might be able to identify through interviews, through surveys, a more of a qualitative set of information and use that as a narrative alongside any quantitative analysis. And finally, another aspect you might be able to do in the context of missing quantitative data, and this is often around in the case early on in an evaluation where you haven't got any impact data, but you might have costing data, is to undertake a break-even analysis where you can enter and understand your costs and work through what effect size and what impact you would need to be able to demonstrate that it's value for money. And as you work over time and impact and effectiveness data becomes available, you could then inform that as part of a later study.
Okay, great. Thank you, Gareth. The next question we have for you is how a specification or evaluation criteria can be written so that procurement can issue a tender and award the contract. Maybe if you have an example or best practice, something like that.
Thank you for that question. I mean, we can look into this, and perhaps if I can reply back to this in more detail at a later date. But what I think the issues here are, it's very much around understanding. I think the stages that you need to go through with something like this to understand the objectives is to think back to the concept of the logic model, really to understand and be able to map out and articulate from your original expenditure what you expect the additional costs to incur in terms of new inputs or changes in inputs, how you can articulate that change through to outcomes and objectives so that within your specification and the evaluation criteria, you are identifying both the intermediate outputs and intermediate outcomes, for example, changes in GP resource utilization, changes in A&E attendance, if they are the issues which are of your interest, and then how that then links through to potential health outcomes. So my view on this is that there is a risk in being too challenging in purely defining these in terms of healthcare outcomes, because what you're trying to understand is as I said, it's the overall logic model and being able to help those who are tendering for the contract to articulate how their changes in activity can impact upon those outcomes. And the way that they can do that is by understanding the links between the inputs, the outputs, and the outcomes that are achieved.
Okay, great. Thank you, Gareth. The next question is, what if there is suitable data available, but you cannot access it in a timely manner? For example, HES data.
This is again is an issue and is a problem. HES data, which is excellent, comes from the HSCIC. They do obviously have a service level agreement in providing data according to a specific time, but clearly that may not fit within your timescales of your evaluation. I mean, one option is to perhaps work with organisations that do have access to HES data, because they hopefully will be able to apply that for you in that context. Secondly, there is an issue here very much around what is good enough for in the interim and what is good enough now, and can further data down the line be used to reinform and enforce that data. So there is always the question that to what extent does an evaluation give you the perfect answer? And the answer is it never does, because there is always uncertainty and there is always risk that needs to be addressed. So my thoughts on this would be that there are limitations and there are constraints to all kinds of evaluations, and data being one of them. If you're, in this case, you may be only able to undertake an interim evaluation, you then may be able to identify an initial step or an initial set of outcomes using something such as cost-consequence analysis, which doesn't give a definitive value for money answer, for example, but lists the potential costs and benefits from those different types of outcomes. And then when more data can become available, for example, if you're able to access HES data, you can then incorporate that in a more of a formative, more of a summative evaluation, which actually defines the definitive outcomes.
Okay, great. We have another question from the same individual, so it may be a follow-up question. It is, can you control for confounding variables within a minimum data set so that you can demonstrate it is the new model of care intervention that has made the difference?
Absolutely, that's a very important question, and it's something which was stressed, I think, and touched on in some of the earlier evaluations. What is needed here is clearly an understanding of the baseline, your current position, and then an assessment somehow of what the counterfactual, as economists will call it in their jargon, will be against the consequences of the intervention. And it is the comparison of the intervention against a reliable counterfactual that is important. Now, one very easy way is to simply take the baseline and to draw a line forward, say with a growth for inflation and or costs, and that would be the answer. But that's not a particularly strong counterfactual. The gold standard is where you're able to undertake some kind of controlled trial with a control group, and you are able to compare the intervention against that control group. However, I fully recognise that that is highly unlikely in the context of pragmatic implementation of new models of care. But there are other ways around it, which are of less robust strength, but equally can give you an indication of the impact. What we're trying to do here is not prove something is right or wrong. This is all, remember, about trying to improve your confidence and improve the evidence base that informs decision making. Very rarely are we in a position of an extreme of yes, we know everything or no, we know nothing. It's somewhere in between. And what we can say here is that other forms of ways of generating a counterfactual can inform that. So you can take historical trends. You can look at other similar areas and extrapolate findings from those similar areas. You can undertake, and there are a range of fairly clever statistical techniques, and if you can have access to a statistician locally or through an organization, they can talk to you about techniques such as propensity score matching or regression discontinuity design, which actually enable you to mimic the effect of a control group using observed data without actually running a control group. We ourselves are doing that as part of a big evaluation in a set of new models of care in North America at the very moment.
Okay, great. Thank you. We have a few more questions. The first one is, what IPR aspect needs to be looked at the outcome of the project in terms of securing rights, background IPR, forward IPR, etc.?
Thank you. I presume here we're talking about intellectual property rights and the ownership of those outcomes and the ownership of what's available. I mean, first of all, going back to what I mentioned earlier, there is something around the intellectual property rights of data. We need to be very clear that if you have access to data and you're going to use it, you have the right and permission of the owner to actually use that data in that context. And if that involves making it published, then you need to be very clear about that. So that's the first thing I would say, is always to ensure that the owner of the data is familiar and understands what you're going to do with this data. Then related to that, there is the whole aspect around what happens beyond that, and I think that very much depends on the local conditions and the local circumstances that exist, because and how that's reflected in the contracts. I don't think there's a definitive answer to it, but I would think that in terms of securing rights and background rights and going forward in terms of IPR and what that means in terms of making data available, it all does come back to how it's been agreed as part of the contractual agreements.
Okay, great. Thank you everyone for your fantastic questions. Unfortunately, we are now out of time, but if we didn't have a chance to get to your question, please feel free to get in touch with Gareth. As a reminder, the recording of this webinar will be available in the next 48 hours on our website, and we will also email it to you. Finally, like we mentioned at the beginning of this webinar is the last in our series of health evaluation webinars. These are all available on our website, so please do have a look. Thanks again for joining us, and we hope you'll be back at the next Optimity Advisors webinar. Thank you.